Thanks, Anthony. Evening, everyone. Just to echo briefly what Anthony said, it's great to see you all here. Thanks from the Bonnart Trust and the trustees, and thanks to Birkbeck for hosting us. It is particularly pleasing to see existing scholars of the Trust here, not only on this side of the table, but also on this side of the table, because this evening we're really pleased to have Dr. Dominic Reilly with us, who I think was a Bonnart scholar from 2016 to 2019. And by way of introduction, Dominic received his PhD from Birkbeck, University of London, in 2020. His thesis was titled Gay Men, Grindr, and the Racialization of Desire of Sexuality, and it was a psychosocial exploration of the racialization of sexual desire in gay men's communities. His research included a theoretically driven thematic analysis of Grindr profiles and biographical interviews with users analysed through a psychodynamic lens. For more than 8 years, Dominic has led projects and programmes of work addressing health inequalities in the sexual health and HIV sector, working for Terence Higgins Trust and currently Central and North West London NHS Foundation Trust. And his work has included a particular focus on health inequalities and inequities that impact the LGBTQ plus communities, including LGBTQ plus people of colour and Black African communities. I'll let Dominic introduce to you what he's going to talk to us about this evening. But I will say, again, to echo Anthony's words, that this work, I think, fits squarely within the Trust's evolving mission, in the attention it pays, I think, to respect and rights and inclusion at the individual level, but also at the level of group identity. And crucially, I think, it talks to the ways academic research can have significant impact and yield significant insights outside of the academy itself. So anyway, we're thrilled to have you here, Dominic. And without further ado, I'll pass it over to you.
Thank you, Keiran, and thank you to the Bonnart Trust and to Birkbeck for inviting me back to speak this evening. So I'm going to be talking on conceptualising race and ethnicity in health inequities work. And the presentation really is a reflection on my experience of doing a PhD in psychosocial studies on the topic of race and sexuality, and then going out into the NHS and working on health inequities projects where race and ethnicity are a prominent aspect of the work. So just to kind of set some initial context for the type of work that I've been doing both in the third sector and in the NHS over the last 8 years. Really, with the work of Michael Marmot, there was a kind of paradigm shift within healthcare that focused on the social determinants of health. And he did that work initially for the World Health Organization, and then was invited by the UK government to write a report which culminated in the Marmot Review in 2010. For Marmot, medicine is failed prevention. So really the thing that he's highlighting is that very often an institution like the NHS is treating symptoms and illnesses that are actually avoidable and are often caused by social determinants, so they would have been avoidable under different conditions. He talks about the fact that disempowerment and lack of control over people's lives creates ill health, and he has an inherently psychosocial formulation of that. So when he's talking about social determinants and the way they impact health, he focuses on the way that they get into the body through the mind and the relationship between mind and body in that way. He talked about it being the best of times and the worst of times in medicine, which is to say that we've never had so many amazing technologies and clinical innovations, but at the same time, we're also seeing increasing inequalities and inequities. And just to kind of highlight this, these things were true as of 2015. They may actually be worse now, I don't know. But on the Jubilee line from Westminster outwards, for each stop, average life expectancy drops 1 year. And in Glasgow, from the richest to the poorest areas in the city, there was a 28-year disparity in life expectancy for men. So those are some of the ways that you can see that social determinants do have an impact at the level of life expectancy and also on quality of life. One of the limitations, I think, of the work that Bonnart was doing, and the reason why there needed to be a further paradigm shift, and really this, I guess, is kind of a reflection on my position coming into this from having done a PhD on racism and race, was he talks about race as a proxy for other forms of social exclusion. And I noted really the absence of race in his work. I don't think he was really grappling properly with race. So as much as I think it's important to think about race intersectionally in relation to other social determinants, I think there was a kind of lack in his work of really properly facing up to race as a phenomenon in and of itself that has an impact on health. So there's kind of been a further iteration really of this kind of social determination work around healthcare, which looks at the influence of race and ethnicity. And this was kind of long discussed. I mean, it's been kind of, 20 or more years that there's been lots of discussions about the impact of race on health. But it was really in 2020 with COVID and the Black Lives Matter movement that it came to a head, I think, for the NHS in particular. So with COVID, if you cast your mind back to 2020, there was a lot of focus from the early days of the epidemic on the fact that people who came from racially minoritized communities were having poorer health outcomes in terms of severe disease and death. And there was quite a lot of focus initially on frontline public sector workers and clinicians being impacted, many of whose stories were told in the media. But I kind of lack of understanding at the time maybe about what the specific forces were that were leading to those severe illnesses and death. And then in terms of Black Lives Matter, I think that happening against the backdrop of COVID ultimately created this slogan, which was that racism is a public health crisis. So that really prompted the NHS to think about what its response to the Black Lives Matter movement and COVID was going to be. And so in 2021, the Race and Health Observatory was founded, which describes itself as a proactive investigator and a critical ally to the NHS, with a strategy to drive race equity in health and care. Preceding that, there was already something called the Patient and Carer Race Equality Framework, which is the first explicitly anti-racism framework within the NHS. And that had been set up in response to a review of the Mental Health Act in 2018, which was particularly focused on the fact that the experiences of especially Black men in mental health services were very poor, lower levels of access to talking therapies, and higher use of the Mental Health Act to section people and restrain people once they were in care. So PCREF is actually something that is now linked in with the work of the Race and Health Observatory, but it is going to become a statutory requirement for mental health trusts from the next financial year. So it will form part of inspections which are carried out in NHS trusts. And so this is the kind of backdrop that I'm going to go on to explore, but just to kind of say that really I am reflecting on my own position and experience in presenting this work. And at the same time, I'm going to, at the end of this, really think about what do I think critical scholars of race from social sciences and humanities can make to this work, thinking about what the mission of the Bonnart Trust is. So in terms of just initially thinking about what some of the reasons are why there might be racial and ethnic health inequities, I think it's important to say this is not an exhaustive list, but certainly one of them in the first instance is that societal racism itself makes people ill. So if we think about that slogan, that racism itself is a public health crisis. And the Race and Health Observatory describes this as the fact that structural racism drives unequal outcomes through deprivation, discrimination, intergenerational trauma, and embedded cultural assumptions. And I think partly this gets at something about the psychic and phenomenological dimensions of race and racism, which Sharon Patricia Holland describes as the fact that race may not be on the body in the sense that it is a social construct, but it certainly is in it. I think there is also the aspect of poor experience of care that's experienced by racially minoritized communities. So the studies, for example, that show that people from racially minoritized communities are less likely to be given pain relief when they're in hospital. There's also the fact that they may experience directly racism whilst they're in hospital from frontline staff. There's also a lack of trust in health and care and other state services. So something that I'm very conscious of working within the NHS is that often we may be seen, whereas the NHS for many people is a trusted brand, for other people, we may actually be seen as another agent of the state, which is something to be suspicious of. And that's something that we really have to overcome in the way that we engage communities. And I think we're starting to see that in terms of COVID vaccine uptake, but also the MMR vaccine program, which has very variable levels of uptake across London, depending on whether or not communities are engaged with their local health services. I think another reason for poorer health outcomes is the intersection of racially minoritized communities and economic marginalisation. And we know that all economically marginalised groups do experience poorer health outcomes, and it has a significant impact on healthcare and health outcomes. And one of the reasons for that is because precarious housing, employment and immigration status have material tolls on health. And they also make it more difficult to prioritise health and access healthcare. So that's something I'm very aware of in the work that I do in engaging with racially minoritized communities from the NHS. That, you know, if you think about that kind of hierarchy of needs, the famous Maslow hierarchy of needs, if you don't have that kind of foundation to be able to build on, it's very difficult to actually prioritize your health if you're experiencing insecure housing, employment and immigration status. So 3 areas that I'm going to focus on in particular are from the PCREF framework. So these are organisational competencies that NHS trusts are being encouraged to develop. And these are kind of ways that trusts might think about addressing ethnic and racial health inequities. And so there's no prescriptive guide for trusts to be able to do this, but I can talk about some of the ways that I've seen this happening, and also in the third sector as well, so within the NHS and beyond. So those are the uses and applications of data, what is called cultural competence, which is really the ability to be able to engage with and work with racial and ethnic difference, and then community engagement. So firstly, uses and applications of data, which is really what data is recorded and what uses is it put to. So data on ethnicity is the thing that's routinely recorded in healthcare. I think if people have filled out a patient registration form, most people will know that this is routinely recorded in healthcare. And the reason that it's being collected is in order to identify ethnic health inequities so that these can be acted on. And the different areas that we're focused on are access to services, levels of access, the experience once you're in care, and the actual outcomes of that care are the things that are being analysed in relation to that data point of the patient's ethnicity. But I quote here Annabelle Sawemimo, who is a sexual health doctor who writes about decolonisation of healthcare. And she wrote about the experience of being confronted with one of these patient registration forms, and says that the bizarre assortment of races, countries and continents made little sense. I couldn't guess at what information they were trying to attain or for what purpose. So I've got here the different categories that are used, and these are standardised and have to be used because different data sets from different NHS trusts and other different parts of the state have to be able to be aggregated. So it's not really something that an individual organisation has a lot of control over in terms of the way that this data is collected. But I think it would be something that the Race and Health Observatory is currently looking at, because in a sense, the categories, whilst they try and capture something of the ethnic diversity of the UK, also fall short of doing that. And there's some quite strange inconsistencies in them. So for example, in thinking about Southeast or East Asia, there's a category for people who are Chinese, but then there's nothing else is mentioned. You could choose, for example, other Asian background. If you're mixed, then you can specify if you're white and Black Caribbean or Black African, but then if you're white and Asian, you're only white and Asian with no ability to specify. But then you can see that the Asian British category has Indian, Pakistani and Bangladeshi. And I think in some ways, these are probably arisen organically as a reflection of the different communities. They're a kind of testament to the history of the British Empire in many ways and patterns of migration, but they also result in this kind of strange hodgepodge that seems somehow incomplete and doesn't necessarily represent the way that people identify. I think an interesting reflection on this is also, recently I've been working with a local authority commissioner around trying to engage Latin American communities, and Latin American communities within this kind of framework become kind of fragmented and split up because of the way that they would identify, which would make it quite difficult to track them. So there's probably some work that needs to be done around that at the moment. And another major issue that we encounter within healthcare is actually around data quality. I think there's culturally a lot of work to do for both patients and staff to really understand what the importance of asking about ethnicity data is. I think at the moment we're asking for this data, and often people don't know why they're being asked for it. They may even be suspicious of why they're being asked, and they don't understand the uses that it's being put to. So I actually think some of the conversation that we're having today needs to be had, in a sense, more publicly, in a way that speaks directly to patients so that they can understand the importance of the work. I think there's also something about collecting data about ethnicity, particularly when it's used as a single data point, where it kind of reifies race back into something real again. It kind of speaks to, in some way, the naturalness or self-evidence of race as a genetic phenomenon, despite the fact that it's not. And I think we saw this to some degree when there was a lack of understanding about why some racially minoritized communities had poorer health outcomes in relation to COVID. And that was down ultimately to social determinants, to the way that people's jobs were pushing them on the front line, to precarious housing situations, multiple generations living in one household, but at the same, in comorbidities. But at the same time, there was a kind of confusion about whether or not there was actually some kind of genetic component to that outcome. And I also see it as well in the work that I do with Black African communities around HIV, where there's a kind of lack of understanding around, and I think that's because of poor communication to patients and service users around why Black African people are at increased risk of HIV. Really, that relates to higher levels of HIV in populations of African countries, in the same way that gay and bi men are more impacted by HIV. Simply put, you're more likely to encounter somebody who's already living with HIV. But actually, in work that I've done with Black African communities, I've had the response that, we really need to tell our young people who are born in the UK about this, thinking that, young people have lots of sex, so they're the people that really need to get this message about HIV prevention. And in fact, the reality is that that's kind of seeing it through the lens of the ethnicity as being the risk factor, when that's not actually the case. So there's a sense in which, if you don't think sort of intersectionally, and in regard to that example I've just given, the intersection would be, was the person born abroad? And actually the emphasis needs to be put on ethnicity alongside migrancy status and country of origin, rather than thinking in this really singular term about ethnicity. So I think that's what we're very often in danger of doing when we don't think intersectionally. And the Race and Health Observatory talks about the importance of thinking in an intersectional way, but I'm not sure that always happens. So I think that's a challenge for us always to be aware of. The second area beyond data is around cultural competence. So as I mentioned, this is really about how organisations work with racial difference. And PCREF describes anti-racism as a process with 3 tasks: naming racism, how racism is operating, and then organising and acting. And one of the key ways that organisations in the healthcare space, and NHS Trust included in this, are attempting to become culturally competent organisations is to do anti-racism trainings. So this was really one of the key ways that I saw a recurrence of academic concepts about race, which I'd experienced when I was doing my PhD, then showing up in the kind of policy space and in healthcare. So anti-racism trainings that I've done 3 now at this point, and all of them have had a kind of focus on the social construction of race and on historicising race in terms of the European colonial project, but also talking about, obviously, the importance of race, the fact that it structures and saturates society. So one way that I would have seen that as a kind of academic concept that recurs is in terms of racial formation theory, which was something that I was studying as part of my PhD, and then it came back through these anti-racism trainings. Just to quickly kind of skip ahead to the last part, I think pedagogically and epistemologically speaking, these are really quite challenging concepts for people to grapple with. And so one of the things about these trainings when I've been sat in them is to kind of observe the group dynamic and the way that people respond to these concepts. And I think they probably have to be part of an ongoing transformational cultural change within organizations rather than as part of a standalone training, because I'm not sure entirely that we equip people through our education system necessarily to think about things as social constructs. And you know, quite frankly, that was something that probably took years for me in terms of thinking about both race and sexuality. You know, my PhD was really about the social organisation and the social construction of sexuality, but that was absolutely something that took years to properly land. I think another thing to note is really moving from academia into a kind of policy space and, you know, the outside world, if you like, is just how often you will encounter still what is called colourblind racism, coined by Vanilla Silver, which is this idea of I don't see race, I treat everybody the same. So very often that's the kind of baseline that you see in these type of anti-racism trainings. And I think it's what ultimately they do as a kind of legacy. In one training, you can quite often disavow people of the idea that the best way is just to pretend that race doesn't exist. So I think also these trainings lean into the psychic dimensions of race and racism. And one way that that often happens for white participants in them is that whiteness is actually centered. So for very many people that will be participating in these trainings, the idea of a white person cultivating their own racial consciousness is a completely novel concept. And it's also one that's quite uncomfortable. So I've talked to lots of people about this. It's very often something that's acknowledged from the beginning of the training, which is just that we need to be able to talk openly and frankly, but that you should expect to feel uncomfortable as part of this training. And I think, again, probably that was something that I was more used to doing as someone who was a wide researcher of race and racism. And then I think the important thing is also that locating racism systematically facilitates grappling with the individual stake in racist structures. So that often allows people to feel less like this is a matter of bad apples and individual actors, and like it's more something that, you know, individuals draw on racist structures at different times potentially and contribute to them. I think also in terms of thinking about academic concepts that carry over, you see the influence of critical race theory in terms of thinking about racism as being something that's pedestrian rather than spectacular. Again, I'm quoting from Sharon Patricia Holland there. And also the idea really that it's not necessarily about people's intentions. It's also about what the effects of their behaviour is. I also wanted to just quickly pick up on the fact that unconscious bias training is something that is quite pervasive in, I think, the public sector. And there's been a lot of criticism of that because I think there was this idea that it essentially encourages people to focus too much on themselves rather than thinking systemically about racism. But I would argue actually that where I've actually seen it in practice, it is actually quite a useful tool for reflexivity, for people to actually think about what their own innate biases are and how they might react to difference in the workplace. So I would kind of defend it and argue that there's probably a place for it, but it just needs to be part of a wider program. So the final competency area is community engagement. And the real key piece here is about the importance of lived experience and also thinking about positionality. So the way that all of our social placements and the way that they intersect affects our perception of the world and our knowledge about the world. So increasingly, the NHS is putting a real value on this, and the health and social care sector more broadly. It's really also, tapping into lived experience as a prerequisite for effective interventions. And what the NHS calls experts by experience, so going out to patients, service users, carers, and co-producing and co-designing everything by default. So we're really kind of past the point now where a bunch of so-called experts go into a room and come up with the solutions to something. Everything is very much collaborative. It involves the end user. So that could be a patient information leaflet, service access pathways, or the whole kind of experience of being in care itself. the kind of resonance that I found with this in relation to my academic work was really the way that within academia, within more critical academia, there had been a push to kind of dissolve the boundaries and hierarchies between experts and subjects. And as this pertains to race in particular, I think, with disciplines like anthropology, it was very often reflective of the fact that the expert, so-called, would be a white person. Subjects were often racialized. And increasingly, there is this need to engage in a more equal way with patients and service users, which is very much about bringing expert lived experience into the delivery of healthcare. So finally, I just think the last thing to say is that there's a kind of whole-scale cultural shift that needs to take place. So really that's in terms of who's actually staffing organisations. And there is a lot of work happening in and around that, but it's very much a kind of long game. It's just to reflect the fact that I think you can't only have this kind of move to include racialized perspectives as patients, it also has to be reflected absolutely in every aspect of the organisation and the senior management. So lastly, I'm just going to finish on a case study about the work that I've been doing in the HIV space. So this is particularly pertaining to ethnic inequities in HIV in the UK. So on the left-hand side there, you can see this is the most recently available data published by the UK Health Security Agency about new diagnoses of HIV. And the key thing that I wanted to highlight is that among gay, bi and other men who have sex with men, the number of new HIV diagnoses is going down. So that's the top line that you can see. And then the kind of, I think it's what starts at the second line is transmissions where women are exposed through sex with men. The pattern continues. Essentially, women exposed through sex with men will overtake GBMSM, as we say, gay, bi and MSM, as the primary group impacted by new HIV diagnoses in the UK. That would be a really significant shift because gay, bi and MSM have always been the most impacted by HIV from the very beginnings of the epidemic. The reason that it's happening is precisely because of an emerging inequity in healthcare, which relates to PrEP, which is the thing that my programme is focused on promoting. So in terms of the way that we do that, just briefly here, this is a quite often used in healthcare illustration that shows the difference between equality and equity. An equality approach really comes with a kind of one-size-fits-all model where you apply exactly the same solution to each group. An equity or an inequity approach is focused on actually engaging with the group, working out what their needs are and coming up with a bespoke solution. So that is very much the model that we use. A bit more context for this is that in 2022, 28% of new HIV diagnoses were in people of Black African ethnicity, while 2.5% of the population is Black African, and 80% of women accessing HIV care are non-white. In 2022, transmissions among GBMSM went down overall, but increased among GBMSM from some non-white ethnic groups. So again, as soon as we start using these kind of umbrella terms to club people together, we also have to be quite conscious of the way that we can obscure diversity within the group and the fact that there may also be health inequities within particular groups that we need to refocus. And lastly then, clinical innovations such as PrEP can widen health inequities. And this has been observed in the US. So one of the things that's happened there is that the group that was at highest risk among GBMSM of contracting HIV was Black gay men, but it was white gay men who were more likely to have private health insurance and be able to access PrEP. So it's white gay men that are on PrEP at higher rates. Overall, it means that even though the clinical solution is there, it's not necessarily getting to the people that would have needed it most. That's not to say that PrEP hasn't been transformative for everybody who has gone on it, because I think it has enormous psychological benefits that allows people to have sex without worrying about HIV. But at the same time, from a population health perspective, it's not necessarily gone to the people that actually needed it most. I think there's some pictures missing here, but that's fine, and I'll just skip past. So in terms of how we actually attempted to address this, we So the program that I manage has got various different projects that sit under it. And as I said, the attempt that we made was really to have a bespoke approach to each group that we were working with. So when it came to working with Black African communities, we really felt that we didn't have the competence within the service that I'm in. We didn't have the networks. And that ultimately, having done a literature review, so I mean, in the interest of talking about how you apply your academic skills, one of the things that I had to do right at the beginning of the job that I do at the moment was come up with the strategy for it, which was very much based on analysing different data sets that were available and then doing a big literature review of where prep inclusion programmes have been run globally, what had worked, what had not worked for different groups. And unfortunately, there were really no examples of where engaging Black African communities with prep had worked really effectively, particularly not in a country like the UK. So we started off with a listening exercise, which was really going out into communities and asking people about their understanding of HIV, about PrEP. And one of the things that we also wanted to do, because we'd subcontracted to community partners, so this was Black African-led organisations, was understand really, as we were using this terminology of Black African, what underneath that umbrella was important for us to know in terms of looking at the HIV data. Were there particular countries that were more impacted by HIV? Were there particular communities that we should be focusing on? So we really needed to kind of drill down in a more granular way. And one of the things that I would say is that when you look at the way that this is discussed at the national level, it's very much still in terms of high-level Black African women, Black African communities. But I think at the more local level, there's really this need to properly engage with what's happening on the ground and go out and speak to communities to understand where the risk is. So we conducted this listening exercise. We spoke to over 100 people, which was through one-to-one interviews and focus groups. And then off the back of that, we produced co-produced a culturally competent HIV prevention resource. And which I'll go on to show on the next slide, we are building community testing capacity. So this is Black African community organisations having the ability to test people locally rather than people needing to go to a sexual health service. We are doing PrEP outreach and PrEP peer champion workshops to cascade knowledge. This is about training people about PrEP and giving them resources to share through their networks. So the resource that we produce, the way that it's different from how we would work with gay, bi and MSM is that it initially starts from a position of very variable knowledge of HIV, which was what we found when we did the listening exercise. And so rather than just being able to go in and say, here's PrEP, this really amazing new medication, we realised that we had to introduce that baseline knowledge as a kind of context to talk about PrEP. And more importantly than that, the listening exercise had really identified an absence of PrEP motivation. And the reason for that was that people didn't think that they were personally at risk of HIV. So this was really different from working with gay and bi men who had been having sex in the shadow of HIV for 30 years, and very many of them were just ready for PrEP as soon as it was launched. So you had this kind of ready-made audience for it. Whereas instead, working with Black African communities, we realised that we had to start from a completely different position to make PrEP compelling. We also had to do that and create that PrEP motivation at the same time as not wanting to scare people and at the same time as addressing stigma and misconceptions in a culturally specific way. And we also, in the co-production workshops, were advised to bring all of this to life by using composite case studies to tell stories rather than just presenting information. So this is a few of the pages of this 16-page booklet, which we, as an example of the kind of community engagement work that we do, we'll be going to Afro Hair and Beauty Expo at the Business Design Centre this bank holiday weekend. So this is a big Black beauty exposition that happens every year. It's 2 days, it's a very pan-London event. And we will have a sexual health stall there where this resource will be distributed, among other things, and we'll also be doing HIV testing and STI testing. One of the things, again, to talk about, which is really different in this work compared to thinking about working with gay and bi men, is actually just talking about a sexual health clinic and quite basic information that's nonetheless really important, like the fact that it's free, because not everybody knows that an HIV clinic is free, that it's confidential and your records in a sexual health clinic are kept separately from your GP record. And also things like the fact that it's open to all, regardless of immigration status, because that was something that came up when we did the listening exercise. So in terms of challenges of tackling health inequity, so I've talked about some of the work that the NHS is doing. I think there's an awful lot to be optimistic about, but at the same time, it is true that the scale of the challenge is it's a long-standing one, and it requires broad social and systemic transformation. The NHS is beginning to step up to its responsibilities, but if we're talking about the social determinants of health, quite clearly not all of that can come from the NHS, and it will continue to be in a position of having to treat symptoms that are caused by other parts of the way that society is organised and other arms of the state, if you like. I would also say that the entire health and care sector is under extreme pressure with rising demand and complex and evolving need, and we don't have sufficient resources at the moment, but it is obviously good that some of this work is being done in the midst of that. I would say health inequities have never been more centred, but they are competing with other priorities. And then finally, the potential for contestation. So I noted that, for example, the Race and Health Observatory has objectivity as one of its core values, and I think for me, I would observe that that's quite a strategic move to attempt to take this out of the realm of politics, because we are at a time when something like this could quite easily be sucked into what is termed the culture wars. And I think that whatever you think about kind of objectivity epistemologically, it's really important that we're able to kind of anchor ourselves to that in order to make the case for this work, because that is the nature, I think, of operating in a policy space. So I think that was quite a clever strategic move by the RHO, but it's just to say that this work is not beyond contestation, and that is also something that has to be grappled with in terms of what the challenges are. So this is my final slide. Really, what can we as critical scholars of race and ethnicity contribute? So I guess I was thinking about the fact that I work in a space that is really occupied by people with clinical trainings, be it nursing, doctors, even people that have come from public health very often have a more kind of, if you like, hard science background. But then I've seen, as I mentioned, this kind of recurrence of theories and concepts that I was engaged with when I did my PhD coming through now into the health and care sector. So I think that one of the things that we can do is certainly to centre race, ethnicity, and to think intersectionally. I think that kind of difficult ability to hold on to race as a social and historical construct, but with real material consequences, which I kind of think of as being like the absurdity, but also the seriousness of race, holding on to those two things at the same time. I think that if you come from a social science or humanities background, you're usually able to think reflexively, and that kind of reflexivity is increasingly really important in the conduct of this work. I think being able to sit with the psychic and affective dimensions of doing work around race and racism, which always remains a challenge, is obviously one of those things, if you are from a racially minoritized community, that pretty much you're doing daily anyway. But for white people, there's this sense of being able to opt in or out. There's that sense of discomfort that I talked about in doing trainings where you're asked to center your whiteness. And I think that's something that you kind of have a training in doing if you come from academia. There's a certain academic and critical rigor. I don't think there's the same freedom or space or ability to be as radical if you're moving into a policy space. But there's definitely more and more of an appetite for research and research skills in the public sector and the private sector. And then also thinking about health as multidimensional and that kind of implicitly psychosocial thinking. I think if you make the case for the social determinants of health to somebody who has a kind of social sciences background, it just makes implicit sense, and it resonates in a way that I think is sometimes quite a bit harder for people with a more strictly medical background to really take seriously. And that's it, so thank you.
To get my head out of the way of that presentation. Dominic, thank you so much. That was absolutely fascinating. And there's going to be time for some audience questions in a few minutes, but I've got a couple to start us off. They may be relatively naive, so
That's
so
fine with that.
so bear with me. I wanted to start with something theoretical, I guess, because you sort of opened with it and then circle back to it at the end of your presentation. And you think you said like the absurdity and the seriousness, or whatever it is. And I think one of the things, I come from a humanities background myself, is when you make the case that race is socially constructed, what some people in other disciplines hear you saying is that you're saying it's not real.
Mm-hmm.
When of course something can be constructed and real, constructed for all manner of reasons of power or politics or even expediency, and have real world effects. How do you square that circle in your work? Because if you're working with people who are, as you say, more in the high sciences, you must come up against that kind of misunderstanding relatively frequently, I'd imagine.
Yeah, I mean, I think that when you're in an anti-racism training is one of the few occasions where people are kind of more forced to lay out their terms and their inherent assumptions. So that's kind of a unique space in some ways, which is what makes it quite interesting. I think the rest of the time that people are talking with more kind of implicit theories of race or ethnicity underlying what they're saying. And I would say that there is still very variable understanding of race, in a sense. I think very often that it is that there's more old-fashioned conceptions of race are still very present in the way that healthcare is practiced, which I think is also why I made the point about I'm not sure yet that we quite know what the level of work will be that will be required for the kind of organizational and cultural transformation that we're actually trying to execute. That I think is not going to be one training, it's going to be a process of continual trainings. One thing I would say is that I have noticed something of a generational shift that I wonder if it reflects changes in the curriculums at medical schools, but I do think that younger, one of the things that I come up against as well working in sexual health and HIV is the idea of the social construction of sexuality and sexual orientation. And I think, and obviously gender being a part of that as well, I think that younger clinicians are much more open to perspectives from the social sciences to critical social theories than would have been the case 20 years ago. So I don't know if that reflects that there's been more of an attempt to bring in alternate perspectives as part of medical curriculums, and that's starting to show. But if it's actually just generationally that people who are medics now are reading outside of medicine and coming up against these theories, and they actually find them interesting and want to apply them in their work.
Thank you. Sort of related, I guess. I was struck by the list of sort of tick boxes that you put up there, and I've had, believe it or not, my own moment of sort of wondering which one to tick. As someone, I'm Irish. I just think, why are you asking? Why is that? Why is that kind of noteworthy? I can make a case for it, but it's certainly sprung to mind. And you mentioned this word like reification, and again, how do sort of systems and organisations, even practitioners within organisations, deal with, on the one hand, the practical need to collect data in that way, but on the other, the fact that doing so kind of reinforces that process of racial reification, as you put it. I mean, is that something that's like a live discussion? Is that trying to be dismantled, or is it just kind of baked in and that's just the way it is?
I think that it is a live problem. I don't know how much it's actually a live discussion necessarily, but I think it's one of the things that probably is part of developing that organisational competency around using data better, but also doing this work around cultural competence. Because I think I do often see ethnicity by itself just treated as a kind of isolated data point and not intersectionally. And I think also, whilst we're beginning, the steps towards becoming an anti-racist organisation, the beginnings of the ideas are there around the social construction of race. But as I said, I think it kind of is a point that probably will take longer to land. And as you say, in the meantime, we're doing work that actually seems to keep making race real again.
Yeah. I want to open to the audience, but just a final, more personal question from me. I hope the answer to this is no, but I wondered if, in your own work, kind of transitioning, as it were, from sort of academia into more sort of practice-based environments, do you ever encounter a sort of resistance along the lines of, this is all well and good, and this is all very interesting, but we're a stretch system, we're under-resourced, this is way down the priority list of things to think about. Kind of take your high-mindedness elsewhere. I mean,
I can say no to that, fortunately.
Great, good.
So, certainly from what I've seen, which is working in third sector organisations in health and social care, and where I am now, there is definitely a significant appetite to do this work, and I think it is absolutely from the senior leadership downwards. So it's something that feels like it definitely has the sponsorship of the right people. I think the challenge in getting there, as I mentioned, is really just around, as you say, there are lots of resource constraints. But I think that this is definitely not the thing that's going to get kind of bumped off the agenda from what I've seen.
Fantastic. Okay, so opening up. I'll just work my way backwards, so starting here.
Got a sort of methodology question. So on the listening exercise, you said you subcontracted or outsourced to Black community groups. Do you have any insight into how there's about 100 people, how that was sampled and what the intersections and demographics were in that? So how it was done and how you came to decide who you represent?
So the initial guidance around that was for us to look at local data around new HIV diagnoses alongside country of birth, and then we used that to look at whether or not we felt there were particular communities that we should be making more effort to engage. The way that people are recruited for that is to actually go out into the community. So those community organisations then mapped out where there were different events, or it might be things like going to a church or some other type of faith community and linking in with a pastor, for example, or we go to things like this Afro Hair and Beauty Expo this weekend and actually directly engage with people. So it wasn't, it may have ended up at some point in some kind of local paper or message board, but it was almost entirely face-to-face recruitment. And the planning was all really kind of starting from those data points of new HIV diagnoses and then planning the outreach accordingly. Thanks.
Very interesting, Dominic. John Powell, former trustee. As you know, the trust has a practical action for its findings as an outcome of the academic work that is done. But I wondered if there was any sort of headline public policy recommendations that could come out of the work you've described. Obviously, resources comes into it. Is there anything else that if you were writing a party political manifesto for the election, I'm not making a political point here, but whichever party it is there something you want that manifesto to say about this?
I think the key thing is that the Race and Health Observatory and then PCREP, Patient and Carer Race Equality Framework, which I presented, I think those are the right institutions, the right frameworks. The key thing is just to make sure that the right resources are put behind them, and actually to create an accountability structure, which is there. Certainly it's going to be the case for mental health trust, but then I think that actually has to be spread across the whole of the NHS to all types of trusts. It can't just be something that's reserved for mental health care. So I think it's really doing more and taking what's there further.
Thank you, Dominic. That was really just so brilliant. I feel like I could listen to that for a lot longer. You know, so I work in a kind of similar space. I work in the community engagement side, so it's got very much working around health and social care and looking at race inequalities. And I guess I'm in charge of just reinforcing a lot of the points that you made, particularly the last one around accountability, that a lot of the frameworks and ideas have been around for a long time, and there's a lot of knowledge around them and understanding. And there is a level of frustration, I think, that so many things sometimes do feel to be reinvented, but the accountability is such an important part of it, that if there are more structures in place around accountability, I think that is a real positive outcome, potentially. There was one point I was going to make around ethnicity monitoring, which is, in my work, ethnicity monitoring is actually really poor across the NHS.
Yeah.
And it's for all the reasons you identified in some ways, the kind of the confidence of staff and the cultural competency of staff to ask those questions and to understand why it's important to ask those questions. But also on the side of the person answering, as you said, the kind of distrust of the state perhaps, where's that data going to go? And I think there's also a really interesting generational difference, how different generations are identifying, which can somewhat skew the data as well. And again, in some ways, kind of the legacy of the empire as well, how generations that first arrived in the UK identified in one way, and then the kind of rise of political blackness as well in the 70s and 80s, and then the movements now around understanding more about our own sexual identities as well. So yeah, it's just sort of a really interesting point you made about ethnicity data and why it's also so important, but the challenges about getting it and the accuracy as well that it is there. But yeah, so a really important reflection about how it reifies the concept as well. Thank you, Keiran.
Yeah, thank you. I think that is definitely, I think it must be across all trusts from the sound of it, that there's a problem in actually recording the data. And as you say, it's the thing of people not wanting to provide it, and then staff not necessarily knowing how to ask the question if it's not been filled out on the form. And again, feeling that it's an uncomfortable conversation. So I think that there's probably a big piece of work to do around looking into those categories and going out and asking people how they self-identify and probably completely redrawing them, which is probably a very complicated exercise. But I think it's something that needs to be done, and as part of that, you might be able to do some public communication around what the purpose of that data collection is and the uses that it will be put to.
It's just on that point, from a sort of broader, I guess, like epidemiological perspective, presumably those categories are non-uniform country to country as well.
Yeah.
So is there a system in place to try and aggregate data? I'm thinking particularly, even between the US and Britain, it would be quite different. There's no.
I don't know, so I don't want to say for sure, but I think that it's not the case, and those are very much our categories. I mean, I think one interesting reflection, say, comparing the US and the UK, is that I think historically this is very much the way that the UK has historically treated race and ethnicity versus the US. There was more of a focus on racial health inequalities in the US than is the case here. But again, I mean, I talked about what's happened with PrEP in the US because of the healthcare system that they have in place there. They've still got enormous inequalities, so they might have had, on one level, some better kind of grasp of it, but it hasn't actually resulted in better outcomes. And in that sense, I mean, thankfully we do have this universal healthcare system in place. And that also obviously makes it easier to implement these types of, easier relatively, to implement these kind of initiatives.
Yeah, I absolutely agree. I mean, it's a fascinating talk, and this is not my area, but so I've learned a lot as well. But I do work in academia, and I just had a question, really, or two questions. One of the things that we're always, when you're more looking at the applied side of academia or research, we're always asked to think about not just the outputs, the outcomes, and the impact. So if you could say a couple of words about how you're going to be thinking about kind of tracing the outcomes of this program, because I imagine it would be very long term as well.
Yeah.
But whether you could also reflect a bit on how the community responded to your engagement, and then your kind of personal reflections on that post as well. So thank you.
Sure, yeah, thank you. So I think it's interesting with the way that you always in these types of programs have to think about the metrics from the beginning. So, because that's the commissioners that are funding it want to know about what the outcomes are going to be and how we're going to measure them. So with regard to working with Black African communities, our focus has been much more on creating metrics that are about awareness of PrEP in the kind of knowledge that it will be a longer term journey. There is actually academic work that breaks down the PrEP journey from the first time that you hear about PrEP to the moment that you're actually in a clinic and starting on PrEP, and there's various stages along the way. It's called the PrEP continuum. So the way that we would think about it with regard to communities that really don't know about PrEP at all is that it's going to be a much more long-term thing, and the focus then in the metrics is on awareness. Whereas with the other two groups that we've really focused on are young LGBTQ people and GBMSM of colour. With those two groups, the focus has been much more on can we actually see increases in uptake in our patient group. So we collect our own patient data, we collect the demographics as part of the patient registration forms, and that's something that we monitor quarterly to be able to say where we've seen increases. So fortunately, I can say with the other two focus groups that we have seen really big increases in uptake of PrEP. The other work that we're doing with Black African communities, it is a longer term thing.
And the responses from the community?
Yeah, I mean, one of the things about the work that we were doing was, we subcontracted that work, but I was very involved in it. So I co-delivered all the focus groups that we did, and I was kind of there on the ground. And there was a very positive response to the fact that we were even there. One of the things about the HIV space was I think there was a lot more funding around it in the noughties that had all then been cut through austerity. So people had been aware of these initiatives that were there, and then they'd all disappeared. So they kind of saw us as the recurrence of something that was from this kind of pre-2010 period. And I think there was an enthusiasm around the fact that we were going out and proactively engaging and asking people's opinions.
I wonder if you had any comments on how training works, this kind of training can work in an NHS structure that has charges for migrant communities. I think it doesn't potentially in sexual health services or primary health services, but where that is the structure that's in place and where there's an extent to which immigration functions starting to be embedded within the NHS, how that training can coexist and work when people are being asked to do that kind of data gathering.
Yeah, I mean, I don't know to what extent that is still happening within the NHS. I mean, my starting position would be that the NHS cannot be enforcing borders because you can't do any kind of health inequities work, I think, fundamentally working with migrant communities if you're going to have a situation where the frontline healthcare staff are expected to do that. I think that would be a very challenging context to do that. Are you asking about a specific example that you're aware of where it is happening?
I think it's happening across the board. I've done some work on migrant women who are charged, and not in this space, but migrant women who are charged for maternity services.
Yeah.
And then if you don't pay, that can be used against you in your immigration application. But there's a huge disincentive to go to a hospital.
Yeah.
Because people are aware that if you can't pay it, your immigration application might be rejected, or you might be stopped at the border upon re-entry. So just wondering about how that can work and coexist.
I mean, I think it's interesting because that's, I think, one of the reasons why we come up against working in sexual health, this idea that people do think that they're going to be charged, or they think in some way that there's a policing of a boundary that's happening, that you will bring the police on them or whatever else. And, with regard to, fortunately, sexual health and HIV, in the way that they are organised, it's as a proper public health function, which is really about free at the point of need population health. But I appreciate that there's clearly challenges in other areas of the NHS where that becomes much more difficult. I guess, arguably it's still as much in need of that type of training, but I can absolutely see the tension there, and I'm not sure I would have the answer to that. Thanks.
Thanks very much, Dominic. It was brilliant, really interesting. I think my question is probably impossible to answer, but I was struck by, as you were talking about, the fact that the NHS is a public service. It's a very important public service, but it's not the only public service. And there are other elements of public service which are facing the same issues, some more obviously than others, some more public gaze than others, so police and prisons will be one. But think of education, where these same issues arise. I liked your analysis of access, process and outcome. You can apply the same lens to what happens in education. We know a lot more about the outcome side of things. But anyway, so my question really is, the kind of thinking that you're doing, obviously a lot of it is specific to health, but a lot of it isn't actually. So my question really is, are you aware that this kind of thinking, this kind of analysis is happening in other public services? And I suppose it's supplementary. Do you think the NHS is a kind of pathfinder in this? Do you talk to other public services? Because it seems to me it would be a great waste for the whole process to be reinvented in 6 different public services. Particularly from the point of view of the citizen, who faces one sort of way of thinking about it when they go to the hospital, and a completely different one when they go to school. So I don't know. So probably impossible, but I'd be interested in your thoughts.
Yeah, I mean, I think in terms of creating there's maybe a couple of aspects to it. In terms of a kind of consistent approach across the public sector, I mean, I think one difficulty is perhaps even within the NHS, it can sometimes be quite difficult because it's often, split into trusts, which each one of which is in some ways a standalone institution. But because you have these national frameworks like PCREF, it means that there's a responsibility for each trust to kind of apply the same approach, even if they get to decide how they do it. I mean, I was thinking in response to your question, I'm not sure it quite answers it, but one of the other agendas for the NHS is to really think in terms of the system. And one of the ways that this has been conceptualised is that the NHS should be an anchor institution. So the NHS is deemed to be this anchor that intersects with, for example, FE colleges, universities, and all of the other kind of public services, employment services, housing that you access in your local area. And that actually you should be constantly fostering links with all of these organisations that creates seamless pathways for the individual patient or service user. And again, that also links into the idea of thinking about health as being multifactorial. So it's not just about the process of actually treating somebody, it's thinking about the housing. Are you employing local people, for example? So something that an anchor institution would be thinking about is, how much of our workforce comes from the local area? Do we have training programs in place to bring people in and train them if they don't have the skills to begin? So I think that systematic thinking is happening from the NHS side. Whether or not it's happening, with whoever has that kind of umbrella view of the entire public sector, I'm less sure of.
Great. Got time for one more question, I think. So, final word to you.
Thank you. Oh, question. It might be outside the remit of your research, or perhaps a bit early, given PrEP as a fairly new project. But I was just sort of struck by the mention of prisons in the last question as an environment where we know there is sex with men who have sex with men that may not identify as gay or bisexual, sexual encounters with lack of consent or dubious consent against a backdrop of austerity and the carceral state being underfunded and overpopulated. Are you aware of any research in the area of HIV transmission prevention in prisons in relation to either the introduction of PrEP or within a sort of race research space as well.
So with regard to PrEP in prisons, that actually is something that I have been sort of tangentially involved with. So the services that are run in prisons are separate from the kind of clinics that I am involved with, but I am aware of them, and it is something that we have been trying to open up discussions about, because as you say, I think there's an enormous need, particularly in the male prison estate, but also in the female prison estate as well, for access to PrEP. I think that my understanding is that one of the primary challenges there is how difficult the staff that work in those services find it to have frank conversations with the people who are in prison about what is happening whilst they're there, and then therefore, again, you go back to this point about PrEP motivation and whether or not you can have the necessary discussion to be able to prescribe PrEP, but it is something that is kind of slowly, probably unfortunately too slowly, working its way onto the agenda, and very much an in-need group.
Great. Well, that is perfect timing. Dominic, thank you so much again, and thank you again all for coming. Please stick around for a drink, and I believe snacks as well, also drinks and snacks. And please join me in showing our appreciation.